Assalamualaikum. I'm Dr. Mohammed Ali Rabbani, and today I'm going to discuss with you the past paper questions of FCPS Part I for the topic of upper limb, and I'm going to discuss with you the questions that appeared in the attempts of August and November 2023. For today, I'm going to go through this scheme. We'll start with the osteology and pectoral girdle, shoulder joint, axilla, arm, elbow, cubital fossa, forearm, wrist, hand, and superficial structures. So let's start with the osteology. You will see each question like this. We will give the stem for options or 5 options, and on the bottom left you will see the reference of the question that appeared, and then I'm going to give you the correct answer or some image or text that is going to support the correct answer. Following a road traffic accident, there is a crush injury affecting the medial border of scapula. Which muscle is most likely to remain intact? So this question is just a fancy way of asking if one of the following muscles it's not attached to the medial border of scapula. The correct answer among this is teres minor. As you can see on the medial aspect anteriorly, serratus anterior is attached, option B, and from above downward on the posterior aspect, there is levator scapulae, rhomboidus minor, rhomboidus major, and that leaves us with option E, teres minor, that is attached right here on the lateral border. I will suggest you to go through these pictures of the attachments of the bones to give answer to the questions like this. One of the very commonly asked questions since the beginning of this exam or any other exam, to be honest, a fracture of the surgical neck of humerus results in impaired arm abduction and loss of sensation on the lateral side of proximal humerus. Which nerve is injured? There are two separate clues to the correct answer. The fracture of the surgical neck of humerus alone gives the answer. This is the clue number 1. And here is the function of the nerve given, abduction and the loss of sensation over lower aspect of proximal forearm or proximal arm. That is point 2. So the correct answer here is from option R, axillary, median, musculocutaneous, radial, ulnar. So axillary nerve is the correct answer. As you can see, the nerve that goes around the surgical neck of the humerus, this is the axillary nerve. While on this topic, you can see this is the axillary nerve, and the nerve that is going behind the shaft of the humerus and is fractured in the fracture of shaft, that is the radial nerve, and the nerve that is just behind the medial epicondyle and it's injured in that injury, that is the ulnar nerve. Let's talk about the second one, that is impaired abduction and the loss of sensation over the lateral aspect of proximal arm. So here is the muscle that is deltoid muscle starting from here getting attached till here. So here is the deltoid muscle. So that is responsible for the abduction of the shoulder joint from 15 to 90 degree. So that's the loss of abduction, and the skin over this area is also supplied by this nerve. So that is the loss of the sensation on the upper lateral aspect of arm. So a few more questions that can be asked from this dislocation of the shoulder joint. If I show you the picture again, the shoulder joint when humerus head is dislocated, it moves downwards before moving either anteriorly or posteriorly. So it leads to the injury of axillary nerve, fracture of the anatomical neck, radial nerve, fracture of the surgical neck, axillary nerve, as was in this question. Accompanying the radial artery was radial nerve was profunda brachii artery. Accompanying the axillary nerve is the posterior circumflex humeral artery, and then there is medial epicondyle, ulnar nerve, and ulnar collateral artery, and supracondylar fractures lead to median nerve injury. Let me show you the arteries again. Here, with the axillary artery, posterior circumflex humeral artery is going either with the injury of the surgical neck of humerus or downward dislocation of head. And here with the radial nerve, the profunda femoral artery is going. And last but not the least, behind medial epicondyle, superior ulnar collateral artery is running with the ulnar nerve. So any of these questions that is posed can be answered from these topics. A damage to the medial collateral ligament of elbow is most likely involved which nerve? That answer can be derived from the MCQs before this one. Medial collateral ligament is the ligament of elbow that runs from medial epicondyle to the ulna, and behind medial epicondyle, any injury that involves medial epicondyle does involve ulnar nerve. So that will be the correct answer. And here is the medial collateral ligament, the triangular ligament shown right here. Here, three bands are shown. So this is the medial collateral, or if we talk about the name of the bone, it is the ulnar collateral ligament. So you can be asked questions regarding both this. A 11-year-old girl is referred for an elbow X-ray to estimate her bone age. Which secondary ossification center of humerus is last to appear? So these are the questions that are usually very least commonly asked, and there is no way around it. You have to memorize the ossification centers, but as far as I know, these type of questions are asked very less frequently, and even in these papers, I think there was 20 or more papers in the question and the papers that I have scrutinized for this video. It was only asked once in the radiology paper. So the answer is lateral epicondyle. I'm not going to into the detail of explaining it to you because it's just for memorizing purpose. One question that have been asked is the one that is last to appear, that is the lateral epicondyle. It appears in the 12th here, and beware, in some books, in the past paper books, the correct answer frequently given is medial epicondyle. That is not the correct answer, and I'm showing you the proof here. However, sometimes this question is confused with another question that is similarly asked. It is last to appear lateral epicondyle. However, the time of fusion with the shaft, the last to fuse is medial epicondyle. So that, in my opinion, that is where the confusion occurs, because last to fuse is medial epicondyle, and to appear it's lateral epicondyle. And I have seen that past paper books confuse these two, and the last to appear, a lot of books mark this as a correct answer. That is not right, so keep that in mind. About radius and ulna, what is Gilazzi's fracture? I have seen this, the fractures, the commonly asked fractures, Gilazzi's, Smith, Cooley's. I will go through them. And what is a Gilazzi's fracture? Gilazzi's fracture is basically the fracture of distal radius. I found a very interesting picture for memorizing. There are two fractures. There is Monteggia fracture and there is Gilazzi's fracture. In Gilazzi's fracture, there is a fracture of radius, the distal radius, and there is a dislocation of ulna. So there is radial fracture and dislocation of ulna. And in Monteggia fracture, it's opposite. There is ulnar fracture with dislocation of radial. So mnemonic that can be helpful in memorizing this is mugger. In Monteggia, ulna fractures. In Monteggia, ulna fractures. In Gilazzi, radius fracture. In Gilazzi, radius fracture. So an asked question that is asked in Monteggia, there is ulna fracture, radius dislocated. In Gilazzi, there is radius fracture and ulna is dislocated. A 45-year-old male presents to the emergency department following a fall on the outstretched hand. He complains of wrist pain, and imaging shows posterior and medial dislocation of distal joint. Technically speaking, distal segment would have been a better word here. Distal segment. Which of the following is most likely diagnosis? There is fracture of Cooley's, ulna, lunate, metacarpal bone, neck of scaphoid bone, and ulna. So here the correct answer is Cooley's fracture. Here again you have to go through the two fractures. There is a Cooley's fracture and there is a Smith's fracture. Try to remember Cooley's fracture with dinner fork. It's also called actually a dinner fork deformity, where the broken segment, they move dorsally backwards and they get an appearance like a dinner fork. And the Smith's fracture, it's exactly opposite. After breakage, the distal end moves downwards rather than upwards. So it goes like this. So Cooley's fracture is the one that occurs in the outstretched hand fall, and here the distal end has moved dorsally. Okay, let's talk about the MCQs regarding the pectoral girdle. I will be starting with the nerves and muscles. Mostly the questions asked here are regarding the function of the muscles or loss of the function of the muscle. And rather than asking the name of the muscle, sometimes the nerve is asked. So let's see. A 33-year-old male presented to the orthopedics outpatient department with an injury to the shoulder area following a fall from a height of 4 feet. X-ray findings show the joint is intact. However, during examination, the patient is unable to abduct his arm beyond 30 degrees. So, after the surgery performs passive movement, the patient can raise the arm above the head, which muscle is most likely injured. To be very honest, I think this part is not very okay. But let's focus on the left, the what is rest. He can abduct 0 to 30, but cannot abduct beyond 30. And overhead abduction is okay. So 0 to 30, it's okay. 30 to 90, it's not. And 90 beyond is okay. Technically speaking, that's not, but let's keep it simple. Which muscle is paralyzed? That has question has been asked more than once. And the answer is, actually the answer is deltoid. Deltoid is the correct answer. Here, it's the first 15 degrees, and in some books it's first 30 degrees. That is supraspinatus muscle. Next is deltoid muscle. Next are the two muscles trapezius and serratus anterior. So you must know the name of the muscle for each segment and the nerves for each. For supraspinatus, there is suprascapular nerve. For deltoid, there is axillary nerve. For serratus anterior, there is long thoracic nerve. And trapezius, there is accessory nerve, also known as cranial nerve number 11. So these are the certain questions that are asked in this regard. So unable to abduct beyond 30 degree, the answer will be deltoid. The muscles that compose the rotator cuff. It's a simple recall based question. They are simply asking which muscle are making the rotator cuff. These are the four muscles you can easily remember by this mnemonic SITS. Supraspinatus, infraspinatus, teres minor, and subscapularis. SITS. And it's handy because these three, supraspinatus, infraspinatus, and teres minor, they get attached to the greater trochanter or tubercle, and the one that remains, the subscapularis, that is attached to the lesser tubercle. So these are the muscles. Anteriorly there is subscapularis, superiorly there is supraspinatus, and posteriorly there are infraspinatus and teres minor. This one anteriorly it's a medial rotator. This one is abductor 0 to 15, and the posterior ones, these two are lateral rotators. And in addition to that, all of them give stability to the shoulder joint, pulling the head towards the scapula. A patient is unable to reach or scratch the back because of an issue of which muscle? Before answering this question, try scratching your back like this. What functions have occurred, what movements have occurred in the shoulder joint? To get to the back, you have extended your shoulder, you have medially rotated the humerus, and you have adducted to reach the back. So we have extension, medial rotation, and adduction. So you have to figure out which three functions, which muscle performs all of these three functions. That is the latissimus dorsi muscle. It is a for pectoralis major. Let's talk about pectoralis major. It's a medial rotator and adductor, but not an extender. It's a flexor. Then there is serratus anterior. Serratus anterior does not act on shoulder joint at all. at least not act on glenohumeral joint at all. Subscapularis muscle, it does not have any effect on these two, and it's not an adductor, it's an abductor. And then we are left with subscapularis, and subscapularis is the medial rotator, but does not perform these functions. It does perform this, but it is not an extensor. So these muscles. And one more question. This is a pictures from last anatomy. And one more question that is asked is its role in climbing. So whenever you hang yourself from some point and try to pull yourself up, that is the extension function at the shoulder joint. Like you pull it yourself up and then you pull yourself up, chin up. So there are questions regarding the climbing. There are questions regarding the chin up movement, and the most powerful muscle here is the latissimus dorsi. And then the question can be asked regarding its nerve supply, and that is the thoracodorsal nerve. And thoracodorsal nerve, that will be my next question. Let me give you some other points. Cannot scratch his back, latissimus dorsi, the nerve cannot stretch his back, nerve damage, thoracodorsal nerve, and overhead abduction. The question that is usually asked as cannot comb his hair, cannot reach the overhead shelf, that is the serratus anterior and long thoracic nerve. I will go into the detail of that shortly. The same topic, during the chin up exercise, a person raises their arm above the head and then lowers a bar in front of his chest. As you go up, the bar will, as relative to the body, will come down. The muscle primary involved in this movement is latissimus dorsi. Okay, and then the same question that can be asked. Actually, it has been repeated at least the 3 times in those papers in August and November 2023 papers. The nerve supply to the latissimus dorsi. The nerve supply is long thoracodorsal nerve. Which muscle is involved in the condition known as winging of scapula or scapular winging? The muscle that is involved is serratus anterior. It's actually a frequently asked question. It has appeared at least twice in these papers. And what is winging of scapula? It's basically the scapula. This is a picture where looking the person from the left side, and this here is the anterior aspect. This is the posterior aspect, and here is the serratus anterior. This muscle, this muscle. So it pulls the scapula forward and keeps the scapula placed near to the ribs. So when that muscle paralyzes, that function is lost, and that's why if you push, place your hand in the wall and push the scapula, at least the affected scapula, creates a distance from the rib cage. So this is called winging of a scapula. Like a wing, the scapula protrudes out. The winging of a scapula immediately should ring a bell. Serratus anterior muscle or the paralysis of long thoracic nerve. And the same question, following an injury of the lateral thoracic wall, there is an elevation of the inferior angle of scapula. So here the winging of scapula has been asked in a separate form. The patient is unable to extend the arm forward. The nerve that has been affected is long thoracic nerve. This question has been asked a number of times too. You can see that question, the serratus anterior one or the long thoracic nerve, has been asked a number of times. Let us move to the next question. After mastectomy for breast carcinoma, a female patient develops the loss of overhead abduction. Which nerve is most likely damaged? So the question options given are axillary nerve, nerve to serratus anterior, radial nerve, spinous accessory nerve, thoracodorsal nerve. The correct answer here is nerve to serratus anterior, may be asked as long thoracic nerve. Now, issue that appears here. Okay, we talked about overhead abduction. The issue that appears here is that I told you earlier the overhead abduction involves two muscles, trapezius and serratus anterior, and they both have separate nerves. Now, when asked a question about loss of overhead abduction, which one of the following will I pick up? Because both of them are given here. Spinal accessory nerve is given here and nerve to serratus anterior is given here. So let us break them down. So overhead abduction, it can be done by two muscles. There is serratus anterior and there is trapezius. The loss of both these nerves will lead to loss of overhead abduction. And this is supplied by long thoracic nerve and this is supplied by cranial nerve 11, also known as accessory nerve. Okay, now to get the answer right, you need to pick up on the other things the loss of the said muscle or nerve will do. The serratus anterior, if this is lost, it can lead to winging of scapula and the other thing that you can pick up on is the place of injury. The serratus anterior muscle is on the lateral aspect of your rib cage or the medial aspect of axilla. So at this point, it is usually injured during breast surgeries when the tail of breast is being dissected. So in the injury, you will see a scenario of mastectomy or in any way injury to the medial axillary wall, or in other words, it can be asked about the lateral thoracic wall. So that's how you will pick up. You will be either given a case of mastectomy or medial axillary wall, lateral thoracic wall injury, and the winging of scapula. However, in this case, you will see either the other function, this is the other function, or this is the injury point. Please forgive my writing, injury point. So the other function that the trapezius does is shrugging of shoulders. So if shrugging, the person is unable to shrug, or there is the drooping of affected shoulders because the shoulder is not picked up, and it runs through the posterior triangle of neck, which is the axillary nerve actually. So the injury is usually the dissection of lymph nodes or injury to the neck. So you can take a screenshot of these pictures. So that's how you will be differentiating the injury of serratus anterior from the trapezius. On overhead abduction, is usually asked unable to comb her hair or unable to reach high shelf or something like that. So you can see after mastectomy for breast carcinoma, that's how I knew that I have to go for serratus anterior and long thoracic nerve rather than trapezius and accessory nerve. The following muscle fixes the scapula to the medial border of the vertebral column. So that's the original insertion. If you know that the muscle that is running from the medial border of scapula to the vertebral column, that is the rhomboides major and rhomboides minor. As you can see, they run, both of these muscles, they run from the medial wall to the midline. So that has been asked in this question. And they keep the scapula near the midline. And if this muscle is paralyzed, the scapula moves away from the midline. Deltoid muscle is supplied by which of the following nerves? Very easy, very simple question. Axillary nerve. It has been actually asked multiple times. And the other questions are thoracodorsal nerve, dorsal thoracic nerve that supplies the rhomboids and levator scapulae. There is a long thoracic nerve that supplies serratus anterior, median nerve, and ulnar nerve. We will go into their detail. They supply a bunch of other muscles, and they have cutaneous supply. A shoulder separation in which the lateral end of the clavicle displaces onto the upper portion of the acromion. It may be probably due to the injury. It's technically not a question regarding the muscles and nerve. It's regarding the joints of the pectoral region and the injury. So you have to imagine an injury where this end of the clavicle moves over acromion. So in able to free this end of the clavicle, you have to break the ligaments that stabilizes it. And the most stabilizing ligament here, it's the coracoclavicular ligament. and this is the coracoclavicular ligament. This is the coracoid process of scapula, and this is the clavicle, and the ligaments that run between them. These are the coracoclavicular ligaments, and they have further two parts, trapezoid and conoids. And case of displacement of in case this joint is dislocation of this joint, it's only possible when these ligaments are torn and the clavicle can move now freely to go to another place like this, that is in this case displaces onto the upper portion of the acromion. So that is the trapezoid and conoid ligaments or coracoclavicular ligaments. Now let's move on to the shoulder joint. One question has been very frequently asked in the August and November papers: which tendon of the muscle crosses the shoulder joint? And you will find other statements like which tendon of the muscle is present intracapsular or present within the capsule of the shoulder joint or glenohumeral joint. The correct answer is long head of biceps. As you can see, the biceps has two heads. There is a short head, the short head that goes and attaches to the coracoid process of the scapula. This is the short head. And then there is a long head. This long head, it moves in the bicipital groove and enters the capsule and runs over the head and get attached to the supraglenoid tubercle. And this part is shown right here. It goes and it attaches right here. So this is the ligament. This is not a ligament. This is the tendon. This is the only tendon that runs within the capsule of the shoulder joint. Which nerve may be injured as a result of anterior dislocation of the shoulder joint? Before going into the answer, be very clear about understanding the anterior dislocation of the shoulder joint. Shoulder joint does not just move anteriorly to be called anterior dislocation. Shoulder joint, it's very like this is the head of humerus. It's very securely placed within the capsule. It cannot just move front. That will lead to the an excessive tearing of capsule and the glenohumeral ligaments. What normally happens is in an abducted position, like someone arm was here, he was hit here, and the head moves downwards. Because the downwards, that's another question, the downwards direction, the shoulder joint is not very much secure because on sides, front, above, and back, there is rotator cuff muscles. On the downwards, there is nothing, there is no ligament. So it can move downwards, but at the same time, the biceps, the triceps, the deltoid immediately tries to pull back up, but it does not usually go back inside, rather it comes in front of the capsule. That is the anterior dislocation. The point I'm trying to make is it has to go down before it comes up to be anteriorly dislocated. So the injury that occurs, it occurs when the shoulder is coming down. So you need to understand what structure is below the head of the humerus, and that is the axillary nerve. And that question is very frequently asked. That is the quadrangular space. That question is very frequently asked, as this is the here is somewhere the head of the shoulder joint. When it dislocates downwards, it occupies this quadrangular space and it injures the contents of this space. And the contents of this space include axillary nerve and posterior circumflex humeral artery. So this question can be asked you in a variety of ways. Which nerve is lost, which artery is lost, which muscle is paralyzed, which area of skin is innervation is lost. And by the way, the muscle will be deltoid and area of skin will be upper lateral aspect of arm, as we discussed earlier in this video. An elderly man exhibits weakness in the adduction and medial rotation of shoulder joint. So you are going to be asked about the muscle function. Adduction and medial rotation of shoulder joint. The muscle primarily responsible for this movement is the infraspinatus. It does lateral rotation, so that's out. Subscapularis, it does medial rotation. It's very strong medial rotator. It does adduction, but it's so and so. It does not. It's not a very strong adductor. Supraspinatus 0 to 15 degrees abduction. Teres major, its adductor, its extender, and its medial rotator. And both of these functions are very strong, adduction and medial rotation. So this looks like a good candidate. and teres minor it's lateral rotator, and its adductor. So the only possible answers are subscapularis and teres major, and as both of these functions are done more strongly here, that will be the preferred answer here, teres major. Okay, so teres major, just to make things simple, any muscle that approaches from the posterior aspect, that will be the extender muscle. Like latissimus dorsi or teres major or teres minor, they will be having extension function. Any muscle that is attaching to the anterior surface, that will be the medial rotator. That will include the teres major, that will include the pectoralis major, that will include the teres major, that will include the latissimus dorsi. And then we are left with adductor and abductor. Any muscle that is going to be attached here on the medial aspect will be adductor, and the one that gets attached here that will pull out, that will be abductor. Now, axilla. Axilla contains brachial plexus, axillary artery, veins, lymphatics, and the most commonly asked questions are regarding the axillary, the brachial plexus, the nerve of the axilla. A patient dozes off in an armchair, awakens with a wrist drop, and diminishes sensation in the posterior aspect of arm, indicating a temporary injury to which of the following nerves. This question can be asked in the two separate points. Dozes off in an armchair, if your he dozes off like this and his hand is swung over the chair or the back of the chair. Now this leads to the compression of the radial nerve against humerus, thus injuring it. So that's how you find it. That's the radial nerve. The wrist drop tells you that's the radial nerve, and the sensation of whole of the back of the arm and the forearm is from the radial nerve. So all of these points separately give you a cue that the injured nerve is the radial nerve. So by the way, this is a very interesting picture from USMLE first aid, and the brachial plexus lesions can be summarized here. You can take a screenshot and study them later. And the one that is I'm going through is saturday night palsy, this drop, and it lead due to the injury of the radial nerve. By the way, honeymoon palsy is the same one, because a person with the outstretched hand and the partner is lying with the head on the top of the arm and throughout the night, and that leads to compression of the radial nerve against the humerus, and that usually occurs in inebriated people who are drunk or who are sleeping with sedatives. Otherwise, a healthy person usually wakes up with pain before anything permanent occurs. A young woman presents with a numbness and tingling sensation accompanied by color changes in her arm. So there is some issue of nervous nature, and color changes mean some issues of vascular nature. There is no muscle wasting of introtia, but she exhibits altered sensation in the T1 dermatome. So the nerve injury has not been so much as to waste the muscle, but it has left an issue with the sensory dermatome. So it is due to. So what has happened is there's the brachial plexus, and in the brachial plexus, this point is has been injured. The C5 to T1, T1 has been injured. So how can T1 be injured? So that is the question that you're going to find out. So you will now have to find any cause that is going to affect the lower chords of the brachial plexus or T1 nerves. Raynaud's phenomena? No, because it's the oversensitivity or overactivation of sympathetic system to cold. Osteoporosis, that's not a good answer. That leads to breakage or compression fraction of the spine and leads to the radiculopathy, the compression. Pectus excavatum, that is the inward bone or excavated concave sternum, that's congenital issue. Spinal stenosis, that's the compression of the spinal vertebral canal leading to stenosis of spinal cord. And right cervical rib, yes, that's the correct answer because it leads to the thoracic outlet syndrome, because that's the extra rib Like this is the first rib here, and this is the extra rib. Uh, Now the brachial plexus has to go over like this, and the lower cord of the brachial plexus will be involved. And at the same time, subclavian artery and veins will be affected, and especially due to the lower pressure affected subclavian vein will compression lead to the congestion of the blood in the arm, leading to color changes. And subclavian artery, if affects, it will lead to claudication, pain, the arm getting fatigued immediately after doing some physical work. An accessory cervical rib arising from the transverse process of cervical vertebra, it's actually C7 cervical vertebra, may cause the compression of which nerve? We have discussed is it's the T1, and that is called thoracic outlet syndrome. Loss of the tricep reflex. Oh, you can see how many times that have been asked. Leads to the lesion located in which region? The triceps reflex has been lost. First, you need to know triceps reflex, then you need to know the muscle, triceps muscle, and then you need to know the root value of the muscle that is being uh, affected. So, triceps is innervated by root of CA7 and C8. So, C7 and C8, these are lower cervical nerves, and so that will be the correct answer. By the way, you should know the root values of basic reflexes like biceps reflex is 5-6, brachioradialis reflex is 5-6, elbow and triceps reflex is 7-8, and so on. Go ahead and check the reflexes of the knee joint, the hip joint, and the ankle joint. I will discuss them in the lower limb video. Inshallah, I will be uploading that shortly. A patient ascended on a mountain while carrying a heavy backpack, after which, that's the one point, I'll get back to it, after which he experienced an inability to abduct the arm, diminished flexion at elbow, impaired extension at wrist, which of the following is most likely site of injury? So the correct answer here is upper part of the brachial plexus. So that is a case of Erb's paralysis. Erb's paralysis occurs when the upper roots of the brachial plexus, either the upper trunk or the upper roots separately, they have been injured. Let's ignore the below. Let me focus first on the cause of the injury. Cause of the injury can be anything that separates these structures from the spinal cord. So in this particular case, the scenario that you have been given, there is a heavy backpack. Here the strap of the bag is placed here. When it presses down here, this cord can be either avulsed or it can be compressed under the load. And the question can be given as the heavy backpack, or the question can be given at a person who puts heavy load on the shoulder and he is a laborer that works that way. You can be asked that. And another issue and another way that can be injured is anything that increases the angle between the shoulder joint and the head, like this. If that angle is increased, here the injury can occur, and here the nerves can be avulsed. Here the nerves can be avulsed, and that usually occurs if a person falls head down and falls on the ground like this, and the head is separated from the shoulder joint, or during difficult labor, the person doing the delivery, it pulls the head too much, increasing this angle. So all of these are the causes of injury, and that leads to the loss of all the muscles that are supplied by C5 and C6 myotomes. So you don't need to remember the muscle, just remember that there is flexion at shoulder joint, medial rotation at shoulder, extension at elbow, loss of flexion at elbow, and loss of extension at wrist, so flexion. And so waiter's tip or policeman's tip. So just get your hand in that position as is shown by the image and see in what position each of the joint is. Your joint is adducted, so abduction is lost. It's medially rotated, so lateral rotation is lost. Elbow is extended, so flexion is lost. It is pronated, so supination is lost. And wrist is flexed, so extension is lost. So all of these can give you an idea of Erb's paralysis. The chords of the brachial plexus are named because of their anatomical relation to which of the following structures. There are three chords: the lateral cord, the medial cord, the posterior cord. All of these are named against the axillary artery. They are named against, to be more specific, if you've been asked, they are named against the second part of the axillary artery. As you can see here in this picture, and here is this is the axillary artery. This is the second part. Here the lateral cord is lateral to it, medial cord is medial to it, and posterior cord is hidden behind somewhere here. So here, like this, there are three are surrounding the second part of the axillary artery, and they are named accordingly. A patient presents with a weakness in flexion and supination of forearm, along with sensory loss on the lateral side. Which of the nerve is most likely to be injured? So here the answer will be musculocutaneous nerve. Why? Musculocutaneous nerve supplies all of the muscles of the anterior compartment of arm. So muscles, if the anterior compartment of arm, the muscles are lost or paralyzed, then the flexion is lost. And musculocutaneous nerve, after running through coracobrachialis between the muscles brachialis and biceps, it goes to the lateral aspect of forearm till it goes to the base of the thumb. So it supplies the lateral aspect of forearm. So all the functions of musculocutaneous nerve have been given in the scenario, and then you are going to be asked which nerve has been injured. Musculocutaneous nerve. Here is an interesting thing about this nerve. It runs through the coracobrachialis muscle. It runs through the coracobrachialis muscle, and it can be sometimes be compressed within this muscle too. So after giving all this scenario, the affected nerve passes through coracobrachialis muscle. The anterior and posterior circumflex humeral artery are branches of. You can see it has been asked a number of times, and these are branches of axillary artery. By the way, you should be very fluent with the branches of the axillary artery. So this is the axillary artery. The first is superior thoracic. The second part gives rise to the thoracoacromial and lateral thoracic. The third part gives rise to anterior posterior circumflex humeral and subscapular arteries. Which structure is at risk of injury within the quadrangular space? We have discussed it already when talking about the dislocation of the shoulder joint. The quadrangular space was the space that was present beneath the head of the humerus. So here was axillary artery, anterior and posterior circumflex humeral artery. Which of the following is among that? There is the axillary nerve. So here you can see this is the quadrangular space. Ideally speaking, you should know all of these three spaces. This is the upper triangular space, this is the lower triangular space, and this is the quadrangular space. So quadrangular space, it houses the axillary nerve and posterior circumflex humeral artery. And here the injury can be due to the downward dislocation of the shoulder joint or even the fracture of the surgical neck of humerus. Let's talk about axillary wall and spaces further. A man sustains a stab onto the upper arm, affecting the floor of the axilla. Which of the following structure is most likely to be damaged? That was one of the most commonly asked questions in the upper limb in these papers. The answer is the intercostobrachial nerve. That is basically the lateral cutaneous branch of the second thoracic nerve, and this nerve, as asked in a number of questions, this is the second intercostal nerve, the lateral cutaneous branch. It runs against the floor of the axilla and goes on to supply the medial aspect of arm. And this is important in two ways. One has been asked right here. You have been asked regarding the only nerve that runs on the floor of the axilla. The second thing is this is the nerve carrying the T2 fibers. This is the nerve that carries the referred pain of myocardial infarction to the arm. So that is another question that is very frequently asked. So referred pain of myocardial infarction is due to, so that will be intercostobrachial nerve. Then there is mammary gland or breast tissue. And lymphatics is the most commonly asked question in this regard. What is the lymphatic drainage for upper outer quadrant of the breast? So it goes to the axillary nodes and mostly anterior axillary nodes. The question some can be asked against the alternate names, that is the pectoral group of axillary nodes. Okay, so the lateral aspect, you should go with the most frequent one. There are four quadrants. The upper lateral one, or even actually all of the lateral one, it goes to pectoral nodes, and nipple as a whole, regardless of its medial or lateral aspect, all of it goes to the pectoral nodes. So that is one question. Upper lateral quadrant, lateral half, nipple, subaerial plexus, all of these goes to the lateral uh, direction into the anterior or pectoral group of nodes. From the medial half, and don't forget that medial half does not include the nipple. The medial half, it majorly drains to the internal thoracic or internal memory nodes. So these are the two most commonly asked questions. There are again smaller nodes, but you should be very fluent with these questions. Other questions, other directions that it can go to: superiorly apical nodes, medially can go to the contralateral nodes, downwards can go to the abdominal subperitoneal nodes, and downwards it can go to the diaphragmatic nodes. But again, stick to the most commonly asked things, that is pectoral nodes for the medial aspect and subaerioral plexus, and internal thoracic or internal memory nodes for the medial aspect. And that can be extrapolated into asking the other route, because lateral as the lateral half pectoral nodes was group of axillary nodes. They went into the central, apical, and then subclavian trunk. However, that went as bronchomediastinal trunk. That the bronchomediastinal trunk that goes to right thoracic duct or thoracic duct on the left side. A woman is experiencing nipple discharge, which lymph node receives lymph drainage from the nipple, as we discussed in the posterior, anterior, or pectoral group of nodes. A physician identified a mass on the mammogram that was not detectable on physical examination. Where it might be located? Here it's a fancy way of asking, apart from the anterior of the chest, where else is the breast tissue located? So apart from the anterior aspect, the breast tissue is located in the axilla, that is the tail of the breast. So that is the tail of the breast, and sometimes pathologists can be missed when that part is ignored. This is the tail of the breast that goes into the axilla. In adult females, the breast is situated above which of the following structures? You should know that breast lies where? Here, pec major, pec minor, serratus anterior, and pectoral fascia. The answer are given. Pectoral fascia will be the preferred answer. You should know that mammary gland, like the other sweat glands, it is present in the subcutaneous tissue or superficial fascia. That's one MCQ, by the way. And just beneath it, this white line that I'm going to make it red now, this is the pectoralis fascia covering the pectoralis major muscle. In most of the cases, the MCQ is it's overlying which muscle, that will be pectoralis major muscle. However, you have been given both of these answers, so you will answer the item that is more attached to the breast, that is more in line to the breast, that is in this case pec major. Purely orange appearance of the breast in malignancy occurs due to the distortion of which structure? Now, that has been suspensory ligaments, and a lot of you will say the lymphatics of the breast is responsible too. Both of you are right, and technically speaking, this MCQ is not very well made to differentiate between these 2 points. So, if this is the purely orange appearance. So what happens is that the lymphatics are blocked, then that leads to the filling up of breast with the lymph tissue. The breast swells up, but as the breast swells and it extends and go beyond, you can see this is the suspensory ligaments that are getting attached to the skin from the pectoralis fascia. So they don't usually stretch with that speed. And as they go, and the points of attachment of the suspensory ligaments, that points the skin is pulled inward and the pitted appearance is shown. So a better made MCQ can be asking you what structure is causing the pitting. In the case of purely orange, that answer will be suspensory ligaments. and the blockage of which structure is leading to pseudo orange appearance, that is the lymphoid tissue. Then you can be asked questions regarding skin dimpling. It is again due to the direct involvement of skin or involvement of the suspensory ligaments pulling on the skin. And nipple retraction. Keep in mind that nipple retraction occurs when duct is involved and the duct pulls and the nipple is pulled with it. A palpable lymph node in the pectoral region of axilla is noted in a patient with a breast cancer. The findings suggest the breast is the most likely located in one of the following areas. So lymphatic drainage is asked in the reverse direction. Rather than saying the upper lateral quadrant is drained into, so you have been asked the pectoral node has drained which of the following area. So the answer will be upper outer quadrant of the breast. And by the way, you should know the statistics that in general the 60% of the breast cancer is in the upper lateral quadrant. So even if you are not given any option and said that the breast pathology or breast tumor, it's most likely to be present in, the answer will be supralateral quadrant. Which of the following technique is most useful in the screening of breast cancer? And that is the mammography, and it's one of the gold standards, the X-ray of basically the breast. It's a gold standard for detecting the breast diseases. Now, moving on to the next segment, that is arm. We're going to discuss the anterior compartment followed by posterior compartment. The man experiences an acute pain after lifting heavy load. Upon examination, there is a swelling in the upper forearm of muscle associated with lateral tuberosity. So basically, after heavy lifting, you're doing flexion, and after that, the pain is in upper forearm. So you have to look for the point of attachment of that muscle, of that the muscle that is going attached on the lateral tuberosity, and that is the biceps brachii. So that's the point of attachment. So that's the point that swelled up and caused the issue. Inability to flex the forearm at elbow resulted from a nerve injury which is attributed to which nerve? Again, flexion at elbow. All of the muscle of the anterior compartment of arm are supplied by musculocutaneous nerve. So that will be the right answer. Musculocutaneous nerve, we discussed it already. In addition to the loss of flexion, it causes the loss of lateral aspect of forearm. Which nerve provides innervation to anconeus muscle? The nerve that supplies is the radial nerve, and here you can see I've given the reference from the Snell's, sorry, this is the text is from the last anatomy, and the picture is from Netter's atlas. As you can see, the branch of the radial nerve that supplies the medial head also supplies the anconeus. So anconeus is supplied by the radial nerve, and I'm putting that much focus in that because a lot of past paper books say posterior interosseous nerve, and it was given with such a high frequency that I was confused. So that is not the right answer. The radial nerve is the right answer, and it is supplied by the nerve that is going to the lateral, that is going to the supplying the triceps muscle. It also supplies the anconeus. Which movement would be impaired due to the significant injury in radial groove? Radial groove houses radial nerve, and after radial nerve damage, the loss of function of all the muscles of the posterior compartment of forearm will result, and that will lead to wrist drop because there is a loss of extension at wrist joint. And keep in mind that when there is a loss of nerve here in the arm, the elbow extension will remain okay because the tricep had already been supplied before the radial nerve entered the radial groove. Okay, so correct answer here is loss of extension of wrist resulting in wrist drop. Elbow. So all of these muscles that will be paralyzed. All of these muscles on the posterior aspect of forearm, and that will lead to the loss of extension of wrist fingers and the wrist joint and so on. Elbow. The injury to the ulnar nerve at the level of medial epicondyle will result in, if medial nerve is damaged, sorry, ulnar nerve is damaged, so all of the muscles supplied by that will be damaged, and the muscles the correct answer is hypothenar wasting. So let us dig into it. If the nerve is damaged here, Then there is 1.5 muscle in the forearm, that is the flexor digitorum profundus, the medial half of flexor digitorum profundus, and there is flexor carpi ulnaris, flexor carpi ulnaris, and in the rest there is hypothenar muscle, there is interossei, and there is adductor of the thumb. So you have been asked regarding the hypothenar wasting, so that is the correct answer. Claw hand is technically also correct. The nerve injury will lead to the clawing of these two fingers, the little and the ring finger. So there will be ulnar claw hand, but ulnar claw hand has not been given, so my preference would go to the hypothenar wasting. Cubitus valgus and cubitus varus are the deformities where the angle of elbow is different and the carrying angle will be increased or decreased. A pediatric patient presents with a posterior elbow fracture and exhibits a loss of sensation in the little finger. Which ligament or tendon is likely to have been torn? If there is an injury in elbow and sensory loss of little finger, again it comes down to ulnar nerve. And ulnar nerve, you can check, there should be medial there is a loss of ulnar nerve, but that's not the question that has been asked. Which ligament or tendon has been lost? So that question was asked in the opposite direction previously. The ligament related to uh, that is related to this medial epicondyle, that is ulnar collateral ligament. So that will be torn. Flexor carpi ulnar tendon. Flexor carpi ulnaris, it's a very important one. Let me get back, show you the ulnar collateral ligament, that I will get back to the flexor. This is the ulnar collateral ligament. This is the triangular ligament from medial epicondyle. Injury to that will lead to the loss of ulnar nerve. And then there is medial epicondyle injury. I will talking about ulnar flexor carpi ulnaris. When it enters the forearm behind the medial epicondyle, it runs between the two heads of flexor carpi ulnaris. So rather than tendon, if you had been asked between the two heads of flexor carpi ulnaris, that would have been a good answer too. And by the way, the two heads of flexor carpi ulnaris and medial epicondyle in front, that is called cubital tunnel. And that is the cubital tunnel syndrome, the injury of the ulnar nerve. Cubital fossa, the most common question asked here is regarding their boundaries and the contents, and which of them is medial or lateral. You can see this question has been repeated so many times. With cubital fossa, which structure is located most medially? I have already given the answer in the text here. The most medial structure is a median nerve. So you should know MBBR, MBBR, median nerve, brachial artery, biceps tendon, radial groove, okay, and radial nerve. So MEBR. Which of the pathway is the median nerve? Again, the same question. MBBR, it's medial to the biceps tendon. It's medial to the biceps tendon or brachial artery. Let us move on to the forearm. Let us start with the anterior compartment. A person is unable to perform supination. Which nerve injury could have been accounted for this loss? So you must know that there are two muscles responsible for supination. There is biceps brachii. By the way, the supination function of biceps often skips the mind. And then there's the supinator muscle itself. The biceps brachii, it is supplied by musculocutaneous nerve, and the supinator nerve is supplied by a radial nerve. So here's the answer. Radial and musculocutaneous nerve is given in the answers here, so that will be the correct option. The most powerful supinator of forearm. Usually supinator works, but when you have to do extra work, when you have to apply force, then biceps brachii come into action, and that is the correct answer. Biceps brachii is the more powerful supinator of forearm, especially when the elbow is in flexed position. Which of the following muscle does not contribute to the movement at rest? Flexor deuterum longus It actually goes to the fingers, but indirectly it does some extension at wrist. Extensor carpi radialis, it extends and radially deviates. Extensor carpi ulnaris, it extends and medially deviates. And brachyradialis, it ends here in the stylet process. It ends at the stylet process of ulna, so it does not lead to any movement at wrist joint. So the correct answer will be brachyradialis. And here you can see from the posterior view and the anterior view, the brachyradialis, it ends right here. This is the brachyradialis muscle. It ends here before crossing the wrist joint. And this is it. Which wrist flexion, which wrist flexor is innervated by both median and ulnar nerve? Wrist flexion is chiefly done by the flexor carpi radialis, that in addition to flexion cause radial deviation. Flexor carpi ulnaris. Medialis, it supplies the radial nerve, supplied by the median nerve, supplied by the ulnar nerve, and then there is a flexor of the fingers, flexor digitorum superficialis, flexor digitorum profundus, and among these, the flexor digitorum profundus is the only muscle that is supplied by the two nerves, that is the ulnar and the radial nerve. The ulnar nerve, it supplies the medial half that is ultimately going to the ring and little finger, and flexor digitorum and median nerve supplies the lateral half that is going to supply the index and the ring finger. Okay, so here these fingers will be flexed. Which nerve innervates the extensor carpi ulnaris muscle? So most, if not all, of the muscles of the posterior of forearm, these are supplied by posterior anterocious nerves. By most, I do not include conconeus. I am focusing it on again and again because that was repeatedly wrong in the past paper questions that I have viewed. So all of these muscles, these are supplied by the posterior anterocious nerve. That is the branch of the radial nerve that dips down deep from the cubital fossa, runs around the radial head within the supinator muscle, as you can see right here, and goes to the back. The posterior anterocious nerves innervates which of the following muscles? Again, the posterior aspects of forearm and supinator muscle is supplied by that, especially when the nerves run within the supinator muscles to go to the back. Loss of finger extension and abduction after injury to the elbow. Finger extension and abduction. Okay, now abduction has been added here. Abduction of the fingers has been added here. It is most likely due to the damage of. It is due to the damage of. I have yes, posterior anterocious nerve, because as you do extension, if you do extension very forcefully, try extending your hands, it fans out. If you do extension very forcefully, it fans out like this. So it's not technically a function of extensor digitorum, but due to the anatomical nature there, when it pulls, the direction of the ligament is such that it does help in extension also. So that is an indirect way of asking that, uh, but still it's not a pure function, but indirectly abduction occurs. So that is a right question. Area of the wrist, it includes the structure that are passing around the wrist, especially the flexor retinaculum and the carpal tunnel. The area of the wrist joint. Which bone is located in the middle of the proximal row of carpal bones? The answer is the lunate bone. There is nothing to memorize here, but I'll ask you to memorize this, to see this picture of the wrist joint from lateral to medial. The first one is the thumb. There is scaphoid, lunate, trapezium, tricutrium pisiform, trapezium, trapezoid, capitate, hamate. We used to remember it with the mnemonics of Fowler and Tinde Paga, Tinde Terekache. So this is the one that is present between the two, the proximal row and the middle one, that is the lunate bone. The medial attachment of flexor retinaculum is to which structures? On the lateral aspect, it is attached to the lateral bone of proximal and lateral bone of distal row. On the lateral aspect, it is attached to the proximal and distal row medial bones. And these two bones will be pisiform. Here, it will be attached to pisiform and hook of hamate anteriorly. So the answer would have been pisiform and hamate, both would be had been right answer. On the lateral aspect, trapezium and scaphoid would have been correct answers. Which structures passes above transverse carpal ligament? Ideally, you should memorize the structures that are passing above this. And here the ulnar nerve. You see, ulnar nerve passes above. Here is the flexor retinaculum. This one, and the ulnar nerve passes above it, and median nerve inside it. Below flexor retinaculum, deep to not below technically, deep to flexor retinaculum. This area between flexor retinaculum and the carpal bone is the carpal tunnel. Any swallowing, if any contents become swollen, the median nerve is compressed, or the bone gets fractured, or just simple edema can lead to the injury of median nerve, that is carpal tunnel syndrome. In carpal tunnel syndrome, the ulnar nerve remains okay because ulnar nerve is present outside the flexor retinaculum. It is present superficial to flexor retinaculum. Which of the subsequent structure does not traverse posterior to the flexor retinaculum? Not traverse posterior का मतलब है it means anterior. In anatomical position, anterior means superficial. So that is the same question just posed another way. Superficial to flexor retinaculum is flexor carp ulnar nerve. Sorry. By the way, flexor digitorum superficialis, flexor digitorum profundus, and flexor pollicis longus, all the tendons passes due to the flexor retinaculum. A 35-year-old male sustains a superficial injury to the flexor retinaculum. Which of the following function is most likely lost? Again, a way of asking injury of ulnar nerve, and then you are going to be asked regarding the actual functions. The ulnar nerve gives supplies to the medial aspect of hand and the thin arm eminence and adduction. So the loss of sensation of ring and little fingers. Abduction of the thumb is done by median nerve and radial nerve. The sensation of forearm, it's before carpal tunnel, and thumb opposition is done by median nerve. A 35-year-old male sustains a superficial injury to the flexor retinaculum. Which of the following function is lost? Again, so it is this ulnar nerve damage. Here in the letter, you have been shown nerve passing underneath. It's not technically flexor retinaculum. It is one of the superior slips of it, and the part from where this is passing, it's not called carpal tunnel. It's called Guyan canal. Again, not very much commonly asked, so I'm skipping it. A patient presents with the pain and bleeding in the anatomical snuff box after trauma. Which structure is most likely damaged? The content of the anatomical snuff box, it's a radial artery. So you can be asked this question in two ways. It's a radial artery, and then there are two carpal bones, the lateral ones, the scaphoid and trapezium, and the radial nerve supplies the scaphoid bone. If the artery gets ruptured here, the scaphoid goes in avascular necrosis. Hand. Which of the following nerve supplies the small muscles of the hand? Very frequently asked question. And then the dermatomes are usually asked, C8 and T1 dermatomes. Not dermatomes here, when supplying the muscles that are called myotomes. So C1 and T8 myotomes are going to supply the muscles of the hand. The 8 is not given, so T1 will be the correct answer. If C1 and T8 is given, that is a very good answer. For the small muscles of the hand, ulnar and median can be an answer. If C8 and T1 is not given, you can pick up T1. And if no other option is given, ulnar nerve is a better answer than median nerve, because as far as the total number of muscles are concerned, more muscles are supplied by the ulnar nerve. Thenar wasting, median nerve. Hypothenar wasting, ulnar nerve. Lateral sparing means thumb is spared, so ulnar nerve is damaged, so thumb is spared. Or if lateral is not spared, it again means that all muscles of the hand has been occurred. So again, that leads to this same C8 or T1. Here's the picture for your reference that you can take screenshot. You should know the elbow flexion is by C5, wrist flexion is C6, wrist triceps is C7, and interossei is C8. So by this you can check the different myotomes and dermatomes. The C5 can be checked on shoulder, C6 thumb, C7 finger, C8 little finger, and T1 on the medial aspect of forearm and arm. In case of median nerve entrapment under flexor retinaculum, which muscle remains unaffected? Let me tell you which muscles are affected. Three muscles of thumb, opponens, flexor, and abductor, pollicis brevis. Two lumbricals. These five muscles are paralyzed. So find out which are not included in it. Abductor pollicis is given, flexor pollicis is given, opponens pollicis is given, lumbricals are given, flexor carpi radialis is not. It is supplied by the median nerve, but it is supplied by the median nerve before it get under flexor retinaculum. A patient presents with a tingling of hand, difficulty in gripping the objects, wasting of thenar muscles. Which nerve is most likely affected? The affected nerve will be median nerve. As you can see, median nerve leads to the loss of thenar eminence. It leads to the loss of flexor digitorum superficialis and half of profundus. That leads to the loss of finger flexion, and it leads to the loss of opposition that can help in the gripping. So all of these losses lead to loss of gripping. Damage to the radial nerve at wrist results in radial nerve if it damaged at wrist. That's an interesting point. If it is damaged at wrist, all of the muscles before that have already been supplied. So there is no paralysis. There will be no wrist drop. There will be loss of only the sensory innervation of the radial nerve that is going on to the dorsal aspect. So there will be the sensory loss of the dorsal aspect. Here, it is very lucrative to pick wrist drop as an answer, but that is not the correct answer. Why? Because the radial nerve has been damaged here. All of it before it is okay. So only loss will be beyond the point of injury, and that is the innervation of the dorsum of the hand and index and middle finger. Identify the muscle that function at flexor at a metacarpophalangeal joint. So this is flexion of the metacarpophalangeal joint. So that flexion is due to lumbricals and interossei. And when both of them are given in the options, pick lumbricals as they are more prominent in doing that. So this can help you remember the function of lumbricals. It is doing flexion at metacarpophalangeal joint and extension at both the interphalangeal joint. So actually clawing that occurs, clawing is the opposite of function of negative image of the function of interossei. If we extend this and flex this, this is the claw hand. When these two lumbricals are paralyzed, you get median claw hand. When these two lumbricals are paralyzed, you get ulnar claw hand. And the exact opposite of lumbricals occur. The extension of metacarpophalangeal and flexion of this interphalangeal, and this is extended due to the long extenders, and these are flexed due to the long flexors. Which nerve damage may result in patient inability to abduct and adduct finger? Abduct and adduct finger pad dorsal abduction dab and adduction by palmar interossei, or both of these are supplied by ulnar nerve. Pad and dab, you can remember the functions by this. Which nerve primary involved in controlling the delicate movements of hand? Mostly go for median nerve. And this question is again very not posed very clearly, but because delicate movement usually involve thumb and finger like you are writing. The lumbricals is controlling these two, and the thumb is opposition by median nerve. So if you are asked musician nerve, so that will be ulnar nerve. If you are talking about these, the ulnar median nerve for the delicate movements, because precision work is done by the opposition of thumb and pincer movement, that is the pinching grip. During clinical examination, a patient is asked to grip a card between tips of the index and the thumb. Which nerve is being tested? Median nerve, because opposition is being actually tested, and the flexion of the lumbricals, that is the Z movement. This is the moment both of these flex this. So that is the median nerve function. This is the supply of the median nerve. Adduction of the thumb is caused by which nerve? Adduction of the thumb is caused by ulnar nerve, deep branch of the ulnar nerve that supplies the adductor pollicis muscle. It supplies this muscle, and this is the adductor pollicis muscle that is supplied by the deep branch of ulnar nerve. Claw hand deformity is produced by the unopposed action of which of the following muscle groups? It was due to the paralysis of lumbricals, and in the absence of lumbricals, the extensor digitorum extends metacarpophalangeal and flexor digitorum flexes interphalangeal joints. So this is extensor digitorum and flexor digitorum. I am not going to discuss this in detail, but this is a picture from the first aid, and that summarizes a lot of injuries of nerve. You can join our course and look for the detailed lectures of the upper limb where I have discussed all of them individually. A patient is unable to button a shirt or hold a pen. All of those involve opposition of thumb. So which muscle is lost? Opponent's pollicis. A muscle attached to the palmar aponeurosis. The muscle that is attached is this palmaris longus muscle. Its tendon gets inserted here in the palmar aponeurosis. This is palmaris longus. In a child with a bleeding with a deep palmar arch following a trauma, what happens? Appropriate action to control hemorrhage. Here you can ask the palmar arch. The palmar arch runs. It is majorly made up of radial artery. That radial artery, it goes back of the thumb, and then between the thumb and the first finger, it between these two spaces, it comes in front and makes this deep plantar arch, and it is supplemented on the opposite side by the deep branch of the ulnar artery. So if you have been asked what is the major source of bleeding, what is the major arterial supply, then radial artery would have been a better answer. However, actually, and similarly for the superficial arch, the ulnar artery is the major artery and the radial artery is supplementing. But it is anastomosing from both ends. So radial and ulnar artery both needs to be pinched to stop the bleeding. And for example, and that is the basis of the Allen's test. So here you can see the pulse of the radial artery. You can see the color of my palm right now. And here is the ulnar artery. If I pinch them both, then the arterial supply of hand is broken. And if I compress the hand a lot and drain my hand and I'm pressing it, you can see the hand, okay, it was not done right. If I pinch my hand, close my hand very strongly and open it, it is white and it fills up with blood slowly. But if I open any one of them, if I open this, it becomes red suddenly. If I open this, it becomes red suddenly. So that's the Allen's test is checking the patency of radial and ulnar artery in case you have to go for radial puncturing the radial artery for arterial tap. So both of these need to be stopped for stopping the bleeding of from either the deep or superficial palmar arch. Fracture of the fifth metacarpal bone is known as, and that is a recall based question that is called the boxer's fracture. When someone hits the wall or hits a hard object with more force than he actually then more force than his actual strength, bone strength, then near the head the fifth metacarpal can be fractured. By the way, you must know about the other fractures. There is a Bennett fracture that we have not discussed previously. That is the fracture near the base of the first metacarpal. And we have already discussed the Smith's fracture, the Pulis fracture, the Smith's fracture, the Montegia fracture, and the Gilaz's fracture. Superficial structures, which nodal region is first affected by the laceration of thumb? At least you must know which node drains the thumb, which node drains the little finger. Which node first drains the thumb? The infraclavicular nodes. if you can see the thumb, if you can follow the lymphatic vessels, they go along the cephalic vein, and the first vein in this group of nodes, this is known as, they have two names. It is below the clavicle, so that is known as infraclavicular node, and here is the deltoid, and here is the pectoralis major, and between them there is deltopectoral groove, so that are also known as deltopectoral nodes also. Loss of lateral palmar sensation and inability to flex index finger. Lateral palmar sensation lost, inability to flex index finger. So this is due to the loss of median nerve, as we had discussed, because loss of the median nerve will lead to the loss of both flexor digitorum superficialis and the lateral half of flexor digitorum profundus, and the loss of sensation of the lateral aspect of hand. Which nerve root supplies the dorsal aspect of middle, actually medial three fingers would have been a better, middle three fingers of the hand, dermatomes. Talk that the little finger is by C8, the middle fingers are by C7, and this by C6. So the shoulder region by 5 and 6, C6 for thumb, 7 for middle fingers, 8 for little fingers, and T form for medial aspect of arm. Damage to the ulnar nerve located posterior to medial epicondyle results in the loss of sensation of the medial aspect of both palmar and dorsal aspect. So it supplies the one third of the dorsal and medial aspect or ventral aspect of hand. Following a road traffic accident, a patient presents with a fracture of surgical neck of humerus, axillary nerve, accompanied by inability to abduct the arm, deltoid muscle loss, loss of sensation of the proximal lateral aspect of arm, which nerve is likely to have sustained damage. We have discussed this previously in detail. That is the axillary nerve, as it supplies the deltoid, and the skin over the deltoid, that is the axillary nerve. So, thank you so much. That brings us to the end of the discussion of the upper limb question. If you have any further questions, please let me know. And let me show you one more very interesting thing. If you want to practice this question, we have a forum. We are working by the name of, we have developed an application by the name of MedEd. Let me show you that. You see, this is a desktop version. This is the MedEd application. You can browse the questions through the topics. Like you can start solving anatomy questions. There are about 1,000 anatomy questions right now from the paper, and we will be very frequently adding more and more of them, inshallah. And then you can go back and you can attempt the papers from the exam by exams. You can click on this and click on sort by exams. So a lot of questions by Medicine Allied, you can go on and trying attempting the questions by exams. And let me show you one more thing. On the lower right corner of the screen, you can see there is this plus button. You can add and you can make a question paper for yourself to attempt. You can generate a question paper. For example, in our course, you recently went through up anatomy, you went through pathology. You just click on pathology and you go through general pathology. There are 145 questions there, and you create the MCQ test. Go ahead, solve them. And any question that you attempt that is not right, the correct answer will be marked here, and you can instant feedback is given, and you go on and attempting the question. And the second thing that I wanted to show you was our this course, that is the our part 1 revision course by Medicos Academics. You can, let me get myself back. By the name of Medicos Academics, we are running a course where we go through detailed lectures on all of the topics that we are discussed with you. There is nerve, pathology, upper limb anatomy, and if you're very interested in going through the actual basic knowledge, developing your basic knowledge behind that, go for our lectures. Or you contact us, we will give you access to the pre-recorded lectures, and then there are tests. You can go ahead and give the test of like the upper limb, and then you can go for then there is all the different modules. We have general, then we have cardiovascular system, including anatomy and physiology, respiratory system, gastrointestinal system. They will open up as you go along, and our contact information is present right here. We have your info and email, our email. Please feel free to contact us if you have any question regarding this or anything else. Please let us know. Will be eager to hear from you. Thank you so much. Have a good night.